I am working for the UK Health Security Agency. I'm epidemiologist, lead epidemiologist for AMR and antimicrobial usage surveillance. And I would like to present where we are with the point prevalence survey on healthcare-associated infections, antimicrobial use, and stewardship, which was conducted in England last year, at the end of last year. So I wonder, there will probably be people in the audience who participated, who supported us there. So big thank you. It has been a massive project for everybody involved. And so yeah, I hope you find the information useful that I'm going to share. So why did we do this? Why was it conducted, a national point prevalence survey? Well, I am preaching to the converted here. I mean, the costs of HCAI to the NHS are massive. I mean, I'm quoting here 2.1 billion were estimated by modelers back in 2016-17. HCAIs lead to prolonged hospital stays of patients, associated deaths, and also affect healthcare workers like you due to infections acquired in this environment. My team, we're also working on antimicrobial usage and antimicrobial resistance surveillance, the use of antibiotics to treat those infections. Of course, it's also driving antimicrobial resistance in an environment where already there's quite a high selection pressure on microorganisms. So another good reason, as you all know, is to try and prevent these infections as much as possible. Just background figure, in 2022, there were an estimated 58 or more than 58,000 severe antibiotic-resistant infections reported, and with more than 2,200 associated deaths. So background data, why now? Why was it felt necessary last year to conduct the survey? One reason was we have done similar surveys in 2011 and 2016 as part of an EU coordinated initiative. So as you all know, we are not part of the EU anymore. So when they conducted their PPS in the last 2 years, we did not. We were not didn't take part in this, but we felt we needed data also not only to be able to compare with the figures that we see in countries on the continent, but also following the COVID pandemic, obviously we have seen huge changes to healthcare delivery, to transmission of infections, and all our trends were interrupted. So just having this baseline information was needed. I'm just showing some data here based on the mandatory reporting on organisms causing bloodstream infections, so invasive infections in England. And it's quite interesting, the green line that you see is the counterfactual, so what you would have expected to see in reported numbers if nothing had happened, if the trend had just continued that we saw before the pandemic. And the blue line is really the figure, the numbers of reported bloodstream infections that we saw, so the real data. And you can see it's really interesting because it varies by organism. For example, E. coli bloodstream infections, we have a PhD student working on this at the moment because, yes, the figures were affected by the pandemic. We saw fewer bloodstream infections because we had fewer surgery, elected surgery, etc., generally fewer patients in hospitals. But what we didn't expect was that following the pandemic, E. coli stayed very low, relatively low. And why is this? Because when you look at the other organisms, that's unusual. Most other organisms picked up following the pandemic. The PhD student is, as I said, is looking into this at the moment, and so far the models, the mathematic models, can explain that 20% of these missing E. coli cases are due to this cohort of elderly patients. Yeah, they have died during the pandemic, but that only explains 20%. So the rest, we are not really sure why this is not picking up more. As you can see for C. difficile at the bottom right, it's the opposite trend. So we were hoping or expecting fewer cases following the pandemic, but we have seen an increase in C. diff infections. So just background data, not really directly linked to the point prevalence survey, but just to show you so we don't really know what is happening sort of at the moment with this change in transmission, change in healthcare delivery, change in patient demographics. So why PBS? If you were involved, you know it was a lot of work and still is for our team. And hopefully sort of the data will lead to, sort of will provide information for making changes on the ground if needed. But why PBS? Why so much work? Because it just provides us a lot more granular information than what normally is being captured, either by surveillance agencies like us, but also for you on the ground. I know every hospital, I mean, you are looking at your data, you're collecting data. But having this snapshot in time with really detailed information on microorganisms, on the usage, on the indication for usage, how appropriate the antimicrobials were used, that's sort of quite rare. And having this at local, national, regional level will hopefully be really, really useful. So we also capture detailed denominator data. So that's just the sort of background rate, how many patients were on the ward, how many out of these patients had an HCI or were treated with antibiotics. It will allow, of course, research. The data will feed into projects, modeling, so transmission rates, etc. And then, so this is more for us. With this data, we'll also be able to validate surveillance data to see what we pick up in our systems is similar to what you see on the ground. And then I mentioned here automated surveillance. This is where we are all moving, because the data sets become bigger and bigger, and it's just changing from how it used to be that a colleague basically pulled together Excel spreadsheets. It's more and more an algorithm sort of cleaning, analyzing, not analyzing the data, but sort of preparing it. And of course, we need sort of checks to be sure that the data captured is correct. So then that was an ask really from colleagues before the survey, that to capture data to allow a better case mix adjustment, because benchmarking, providing what's seen in one hospital, to be able to compare this with a similar hospital is important. And for this, you need to adjust for your patient mix, for the specialties in your organization. And again, that's where we hopefully these data can be used. Now I'm coming to the methods. What did we do? So study areas, sort of all acute care, community and mental health trust, NHS trusts were invited to participate in the study, as well as independent sector acute care hospitals. This is the work that we did on our side, materials that we developed, a lot of this based on previous rounds on PPS, because we wanted to make it comparable to previous data captured, as well as to internationally sort of conducted surveys, as I said, on the continent, with 27, or not all of them participated, I think 25 countries collected data last year as well. It makes sense to try and keep your definitions more or less the same. So a protocol was developed by us, a code book for all these definitions used, flow charts to just make the definition or sort of the data that you have, a patient record, and how do you sort of get to the code for an HCI, for example. There were paper data forms. And then we manned an inbox, which provided a response to any questions participants had within 24 hours. The data capture system, the evaluation shows that was one of the most critical points, and hopefully in the future that will be easier to use. But we used our own in-house data capture system that's also part of the mandatory surveillance. Software was developed for this, and the whole team behind the DCS helped through the point prevalence survey. And then we had an FAQ, frequently asked questions document to help with responses to the inbox, and just sort of to align this across different teams that responded or were involved in presentations. So again, if you have participated, you will know this. Just to give everyone an idea of sort of how complicated and how detailed the whole project was. So this is the inclusion of patients into the point prevalence. The criterion was that the patient had to be on the ward at 8 a.m. in the morning. If they were admitted later, they were not eligible for participation. And then you can see these various scenarios, what could happen to a patient on a ward being transferred to a different ward, then they would be excluded. But if they went to a different ward but came back to the ward of the survey, they were included. So, I mean, this is necessary to have standardized data to be able to compare like with like. But yeah, not straightforward, and we provided training beforehand, several sort of training sessions, but I have to admit it wasn't easy. But we have a beautiful data set now that we are currently analyzing. I was hoping to be able to present the national results, or at least some of them today here, but we haven't. We have an internal launch event next week, and for participants then the week after on the 30th, and that's where we will present the data for the first time, and will go public probably in June. So again, just to show the enormity of the task, so these different data sort of modules that we captured. So this is the patient level data. So for each patient on the ward, this form needed to be completed, no matter whether they had an HCI or not, or whether they were on antibiotics or not. This provided patient demographics, risk factors. There's a question about devices, McCabe score, so how unwell the patient was, whether they were expected to survive for a certain period of time. Again, all just to be able to analyze the data afterwards in a meaningful way and to adjust to make them more comparable. We captured antimicrobial use data with the aim to understand what the treating physician or the prescriber was aiming to treat. So there were these questions about indication and intention. We captured information not only on antibiotics and antifungals like in the previous rounds. This time we added a few key antivirals. And this is the last bullet point is about the definition of being on an antibiotic, so either on the day of the survey, or if it was prophylaxis, then the 24 hours prior to the survey. Another form, this is for the antimicrobial usage data, and this is the one where we have really added a new element. So on the right-hand side, this box, optional, I don't know if you can sort of see this. This was added by NHS colleagues, Kieran Hand, sort of the NHSE's lead antimicrobial pharmacist, to sort of be able to judge the appropriateness or get an idea about the appropriateness of the prescribing. So we have questions there of number of missed doses, whether a local or national guidance was used, or whether this antimicrobial was part of a local or a national guidance recommendation. So this is optional, so I don't have the final figures yet, but we hope that many colleagues have completed those recorded the data, because obviously that will be really interesting to see now with sort of a new action plan on antimicrobial resistance coming next month, and sort of trying to tackle or continue to improve antimicrobial stewardship activities. And this is the survey, or this is the template that was used for this new antimicrobial appropriateness question, for the questions. It's based on an Australian national survey where they did the same a couple of years ago. So we used the same questions because they had been tried and tested. And again, we will be able to compare with other countries. This is sort of the data flow diagram for the definition when a patient was identified as having an HCAI. This was the data capture document where colleagues sort of recorded the data. This is focusing on the HCAI and the microbiology behind it. Now we're coming to ward level data. This captured data on indicators, structure and process indicators, to inform IPC and stewardship initiatives. And then currently we are still sort of, we have been in contact with many of you or many of the participants for these hospital data because they weren't collected during the survey period. They can still be submitted now. So again, this is about the size and performance or process structure indicators at the hospital to inform IPC and stewardship teams. This is the timeline of the survey. It was conducted between 18th of September and 27th of October last year. Normally, the plan was, as you can see on this on the graph itself, the 27th of October is in red because the originally planned date was the 13th of October. Normally, you try to keep this survey period fairly short because, again, it's about the comparison between organizations and also with previous rounds. And of course, you have seasonality in there. You will have different case mix if you keep your survey period, the windows of too long for the data capture. Why we had to amend it, why we had to revise this data was really quite stressful, I guess also for everybody involved because of the industrial actions. We had the strikes from junior doctors and consultants during this time period. And of course, you don't want to capture data from a highly unusual day on a ward for such a survey. You want as normal as possible data set. And so that's why we extended the period. So yeah, it started in September with a registration of participants. We had the national webinar about background and why we are doing it. Another webinar to answer questions, then the registration of participants, another national webinar in September, and then the actual data collection period and completion of sort of additional data and valid quality checks by the end of November. And these are results. So 124 trusts and independent sector organizations participated. Actually one more, but they withdrew following the survey period because they felt that it wasn't representative what they had collected. We had 67 acute general NHS England hospitals, 22 mental health trusts from the independent sector, 16 organizations, and acute specialists, 10, and 9 community health trusts. And this is the mental health and community. I would like to sort of point out they were not invited to participate in other rounds. So we're really, really curious, really interested what we'll see there, because obviously very different settings in terms of HCI and antimicrobial use compared to sort of the big specialist trusts, for example. So we will separate, or we are analyzing them separately as well. So what we have already provided to participants is the results for their organization. When I say we are analyzing at the moment, this is now the summary data and sort of more in-depth analysis. But at the beginning of February, we shared with each participating trust their own results. And this is sort of a mock table that was included in these reports. We also provided PowerPoint slides, so to facilitate communication within trust or within teams. This is one of the tables that was on one of these PowerPoint slides. Just an example, just to give you an example how this looked. This is sort of the oversight sort of summary table. So Trust X had 4 hospitals providing data. And in this table, we sort of gave the figures for how many patients were covered for this trust, how many out of those patients had an HCI following the definitions of the protocol. Then the prevalence, so the percentage of these patients, then patients that were on antibiotics at the time of the survey, and then these different devices and patients with devices like CVC, PVC, and urinary catheter. So we hope the benefits of participating, as I say, it was a lot of work. And we are hoping that the data will be used, the slides that we provided, the tables, and going forward, so publications, further publications. It will give everyone an idea of the burden of HCI and antimicrobial usage in those settings, how it has changed over time. We'll look at previous rounds, sort of to try and better understand the demand for antimicrobials. We are also sort of working closely together with the Department of Health, and probably you are aware of sort of the sort of high incidence of streptococcal A infections last winter, where we saw this huge demand on antibiotics. And to be honest, I didn't really know this, but how fragile this chain is of antibiotics. So we have the manufacturer, and if they, after a pandemic, don't expect a huge demand, and then we see an outbreak like this, then it can quite quickly sort of get quite tight. So these figures will also sort of feed into, again, as I said, sort of these forecast models. The data you will be able to link HCIs to indication of and use of antimicrobials. Then this benchmarking element to see sort of your trust, your hospital, how they sort of compare with similar organizations. The case mix adjustment, again, that was a request from NHSE colleagues. And so this appropriateness module of the use of antimicrobials, and then post-COVID baseline. So yes, I hope that all the work was worth it and that the data will prove really useful. I would like to acknowledge everybody who was involved, so all participants, colleagues from NHSE and UKHSA, the national and regional teams. And then last but not least, but not listed here, is the UKHSA's PPS team. They have also done sort of, an incredible job. So yes, get in touch if you have specific questions. We are more than happy to answer, provide any material that we produced if you want to do something similar on a sort of smaller scale. And we're trying to get the results out as soon as possible and disseminate as widely as possible. Thank you very much.